So I'm going to talk all about distal radius fractures in 10 minutes and get you from the very simple to the very complex. But the idea of the talk here is to tell you a little bit about how to get from a fracture that looks like this, where you're like, sweet, either I'm going to treat it non-operatively or just put a volar plate on, to thinking about fractures like this and how you can manage the in-between and how you can break it down to kind of piece by piece to figure out how to manage them in a somewhat easier fashion. So how do you get from the simple to complex? Well, I think there's kind of a few principles to know. You really need to know your radiographic principles, your approaches. That should kind of be your background knowledge. Know what the key players, the cortical fragments are for every distal radius fracture, and then know what your implant options. When you have all that done, it should be able to move stepwise as you analyze your fracture fragments. And I think everybody here probably knows the basic principles, looking at your inclination and your tilt and your height. You also remember when you're looking at a native distal radius fracture, that volar rim, that sclerotic rim, that's the volar piece. In a fracture fragment, it's usually the dorsal piece is the more proximal one that you tend to see. And then make sure you're looking at a good lateral where you see that your pisiform is overlapping the distal aspect of your scaphoid and your capitate. Those are kind of the basic principles that everyone knows. But if you're thinking about it on a more like complex level, a few of the pearls that you want to look at, really look at your fracture fragments. Make sure that when you're looking at a lateral, think about looking at the lunate, making sure that the width of the lunate, the A to P distance, should be about the same as the A to P distance of the distal radius. As you can see the image on the right there. The other thing is that the central axis, so halfway through the lunate, should actually bisect that kind of volar margin of the radial shaft. That helps you with alignment. If it's not, you have to think about volar subluxation. Think about the teardrop angle. Most of the time, you're not getting a 10-degree lateral tilt in clinic, but you may get it in the OR, which really uncovers that lunate facet fragment because it's off angle on a true lateral. And that angle, which is the angle, bisecting that teardrop and perpendicular to the shaft or in line with the shaft there, should be 70 degrees. In most distal radius fractures, that tends to diminish. It's dorsally angulated, or sometimes that piece kicks back. And so when that teardrop angle is less than 70, it makes you think that you really need to assess that lunate facet. So when you look at approaches, there's a lot of approaches to the distal radius. There's our standard FCR, which everyone is doing, which gets you down for kind of that standard distal radius where you're going to put a volar plate on. There's the extended FCR, which if you have a smaller lunate facet piece you want to think about, that's extending it in an oblique angle across the wrist joint. There's a volar plus, which means you're adding either like a percutaneous dorsal incision or an additional dorsal incision to perhaps capture a dorsal fragment. There's your direct radial approach. So if you have like an isolated radial styloid, you could think about putting a radial styloid plate. The extended carpal tunnel or the ulnar approach, which you can see in the right here. These are pictures from AO that shows you that you're doing your carpal tunnel and extending it, coming down the ulnar side and going in between the neurovascular bundle and your flexor tendons. That can get you directly, like if you have an isolated lunate facet piece. And then finally, there's a dorsal approach, which you can use for dorsal specific plating or you can use for your dorsal spanning plate. And so it's really important to kind of know all of these procedures so that as you analyze your fracture fragments, you can think about this. So the 5 key cortical players, and if anybody hasn't read Rob Medoff's article in Hand Clinics, which kind of goes over all of this, it's great to look at. But every single fracture that you look at has at least one of these fragments. And there's, typically an intra-articular impacted fragment in the like severe axial load injuries. There's always a radial column fragment. You have your dorsal wall, which may be just a very small piece or can, compromise. It can be up to like 50% of the articular surface. Then you have your volar rim, which is also known as the volar lip or the volar lunate facet fragment, and then the ulnar corner. All of these fragments are really important to analyze and figure out how you're going to fix these. But what I really wanted to focus on kind of for the rest of the talk is that volar rim piece and that dorsal ulnar corner, because those are really critical when you think about what your management is. These are kind of the 2 most important fragments to think about. So why is that volar ulnar corner really important? I think we all know that's where the short radial ulnar ligament attaches. And so therefore, if you have a fracture there, the fracture and the carpus tend to follow that piece. So that's why we will often see volar subluxation when you have a volar Barton piece or an isolated lunate facet piece. what you can see in that cadaver shot right there is that the volar slope of the ulnar side actually projects not only more distally, but more volarly, and that's why you have to get that teardrop angle so that you can see it. It's actually off plane to the axis of the radius. The lunate facet bears most of the weight of the radius. And what you can see here in the bottom corner, this was actually a great study that was done where they looked at CT scans of 23 people that had lunate facet fractures to show where the most common kind of fracture pattern was. This was done in the Journal of Wrist Surgery in 2022. They mapped them all out, and what they measured literally almost everything that you can imagine. They measured size, displacement, translation, subsidence, ulnar translocation, so many other things. But what they classified these into 4 fracture patterns. The more red that you see on the right side is a more common fracture pattern. So these are lunate facet fragments. In addition, they have other distal radius types, but there's type 1, which is just a short radiolunate, then there's a short and long radiolunate, and then there's a radioscaphocapitate, and then the 4th one is a really comminuted one with a dorsal rim. And so what they're showing here actually is that the smaller the fragment was, that the more actually subsidence and the more volar translation you ended up having. So it's really good to kind of think about which type of lunate facet fracture you have here. Another study that was done is looking at that isolated volar lip, and what they showed, this was a study done out of Kaiser patients retrospectively reviewing their outcomes, and what they showed is that the smaller that volar lip fragment, measured on the right side, looking at that sagittal length there, and on the AP looking at the substance of the lunate relative to the ulna, the distal portion of the ulna, is that if you had a fragment that was less than 15 millimeters, or if you had more than 5 millimeters of subsidence, it was a risk for failure even if you used a volar locking plate. So these are the pieces where you say, ooh, that's a really small piece. Now I need to think about some other type of fixation, right? And so you can see on the left here, that's quite a large piece. You can see the CT scan, that axial cut, which shows you that's quite a large piece. On the right is a much smaller fracture fragment with some associated dorsal comminution. So as you're thinking about it, the one on the left is pretty simple. You can either do a straight, trans FCR approach, or you can do that ulnar-sided approach to get down to it and do fragment-specific fixation. But on the right side, you have to think about additional potential fixation. And so this one, which showed dorsal comminution, et cetera, you do a volar locking plate, and then we used a rim plate on top of it. So implants of choice, you can use K-wires, you can bend the K-wires, you can bury the K-wires, you can cut the K-wires, you can use that volar locking plate with additional fixation. As you see in the bottom middle, that plate has an extra rim over the top. If you need to supplement it, you can put dorsal spanning plate on it, or you can use fragment specific. So there are a lot of ways to think about these fractures. You just have to know what you have in your hospital and what the size of the fragment is and what the other associated fracture fragments are. So if we move on to that dorsal ulnar corner, this is kind of the second part that is really critical. There hasn't been as much great studies out there on specific size, except for one that was just published this year by our colleague, Dr. Shapiro. And what they did is they did osteotomies. So this is a cadaver study, and they kind of made sequential size osteotomies in that dorsal lunate facet and showed that if it was more than 40% of that dorsal articular surface, if it was more than 40% of the entire surface of the distal radius, then you could have radiocarpal instability. And so that is critical when you're looking at the axial cuts to measure that length, because if that's the case, then you have to think about doing some additional potentially dorsal, like a dorsal incision and a dorsal fixation or a dorsal spanning plate, or figuring out a way to grab it from the volar axis. And so you can see in this study here, if you look at this case, particularly in the image on the right, you can see that there's a dorsal fragment, and then kind of even outside of that circle, there's another fragment that you see, and it's like, well, that looks quite large. I'm not exactly sure what's going on, but there's also this volar lip fracture that you could obviously see with a teardrop angle. And so when you get the CT scan on this and the floor on the right that was done intraoperatively, you see there's that really large dorsal fragment. Those fragments can flip 90 degrees. And so when you look at the CT scan here, you can see that it's quite a large dorsal fragment. There's the additional volar rim fragment. And then when you look at the axial cuts here, you can also see how big that dorsal rim fragment is and the comminution that's associated with it. So as you approach this fracture, you kind of have to think, okay, let's go dorsal. Let's fix that large fragment first, or at least grab it. right? It's large enough that I think we can put a plate on it. This is actually one of Dr. Shapiro's cases, but you can put a dorsal, some type of fragment-specific fixation, either a dorsal plate, you can grab it through a use of a volar plate, but ideally flipping that piece over, it was rotated at least 90 degrees here. Once you get it held in place, you come volarly, you can do your volar plating to get that lunate facet piece, and then you can grab that dorsal lunate facet. If you can't grab it with a screw, or if you don't feel like you have enough fixation with the screw, once your volar plate is in, you can actually use an associated dorsal plate. Some of the plates actually have it so that you can put a cannulated screw over that volar screw and grab a small fracture fragment, but this fragment was big enough to add on a dorsal plate. So this is kind of like the volar plus approach, doing a volar and dorsal incision. And then kind of last thing I wanted to talk about is what you can see here is, know your implants, know what you have. You have your volar plate with the associated cortical cannulated screw like you see here with it on the top left. It has that cannulated screw that you can do with a small incision dorsally and cannulate over a volar screw there. You can do a dorsal specific plate, as you can see in the image in the middle. You can do a dorsal spanning plate. You can do K-wire fixation. And so what you can see here, this is actually a case from yesterday. And so what you see here is there's this dorsal rim comminution here. There's also, it looks like a radial styloid fracture. This is actually a couple weeks old. So clearly those volar ligaments are destroyed here, and there's dorsal translation through that fracture fragment. And so as you're thinking about it, and you're looking at these fracture fragments, you can see on the left side that there's a lot of dorsal comminution. There looks to be a relatively large radial styloid piece. The lunate is clearly dislocated here. Those volar ligaments are either attenuated or ripped off. It's hard to say where they are. But you can see that there's that intra-articular piece and a lot of comminution. And so as you think through this one and you're really struggling what to do, and this was like a hard case to think about how to do it because we knew we had to go in to get those incarcerated volar ligaments out. When we went into the case yesterday, this is a volar picture with the distal portion at the top, and you can see that that fiber wire is actually looped around the volar ligaments. So what we tried to do is grab those volar ligaments. You can see on the right side the radial styloid fracture. We were able to grab those and pull them back, and we used a couple suture anchors into the articular margin that actually still didn't hold that lunate facet because the ligaments were stretched out, and so it kept falling off that dorsal rim. And so we actually had to come in and supplement it with a dorsal plate. And you can see those K-wires in that small radial styloid fragment, which was actually really small. We tried a just large dorsal plate first, but it actually couldn't capture all of the comminution. So we have a small fragment-specific plate and then a dorsal locking plate on top of it. So this is kind of incorporates all of this stuff, but this is really what you want to think about when you get these. Just remember, look at your radiographs, look at the CT, measure those sizes, be really specific prior to your surgery. Know your approaches, that should be your background knowledge, like I said before. Know what fragments you have and what fragments you need to address. And then finally, know what you have available. And in complex ones like this, you need to ask for a lot of stuff. So it's okay to ask for like the dorsal spanning plate, fragment specific, and a volar plate. If you're not sure what you're gonna need, just make sure you have it there and available. So thanks.